series of our fictional COVID-related cases in mental health settings. For anyone who's missed the series, they're all accessible on the medical education website, and you'll also get, after this session, an email with the links to all of the 9 cases. As ever, the presentation is designed to be interactive, so we very much welcome your comments in the chat box. Please remember to share with all attendees. This week, I'd like to thank Elinor James for the inspiration for the case, and our expert reviewers, Catherine Marshall, Richard Latham, Ellie James, and a special thanks this week to our expert reviewers, Lenna, Adley, and Mack, McLean from ELFT's People Participation Team. As ever, huge thanks to Dr. Cate Bailey and Dr. Lynsey McApline for leading on the teaching and delivering such high quality learning to us each week. Over to you guys.
All right, hi, welcome back for week 9.
Yeah,
into short, Kate?
Yeah,
Social distance. All right. Right, let's get started with a couple of updates. Do you want to talk about this?
Yeah, definitely. So some of you might have seen quite a big paper in the BMJ this week. The first kind of really large UK study of the clinical features of patients in hospital with COVID-19. So more than 20,000, which comprises about 34%, they think, of the people that have been in hospital with COVID. So it's a decent kind of sample. We've got the link to the paper there, but I guess the headline for us and kind of relevant to our case presentation last week, oh, that's really cool, is that confusion is actually kind of the 5th most common presenting symptom at time of kind of arrival to hospital. So certainly there is kind of a lot of delirium associated with COVID, and probably some of the comments from geriatricians and old age psychiatrists are that actually there's even higher rates of that in care homes, where kind of confusion, anorexia, other kind of atypical symptoms might be even more common in the older population. Interestingly for you guys also, as you can see, we're not really sure about any eye symptoms. So there doesn't seem to be a major feature of people with COVID presenting to hospital. So you can make of that what you will. I'll leave that there.
I suppose if people are presenting with eye symptoms, so we
Yes.
probably want to advise them against driving.
Advise against driving and see your doctor. It may not be COVID related, I guess is the one thing to say, although there's some kind of, as you can see from the bottom, unknown kind of conjunctivitis, so jury's still out basically. Nice updates this week. There's a new guideline on managing AKI associated with COVID-19. I think we've kind of discussed this as part of previous cases, but as we've kind of talked about, COVID can do a lot of mysterious bad things to your brain. It can do that to your kidneys as well. Of course, we know that volume depletion, organ failure, and thrombosis are things that are bad for kidneys, but there's also some potential for direct kidney injury and rhabdomyolysis, which we're also seeing. The guidance is quite extensive, but essentially the headline is like trying to maintain kind of a normal fluid status is the way to go, but that can be quite hard to calculate because fever and respiratory distress cause losses. And of course we know from patients on our ward that actually monitoring urine outputs and things and even fluid intake can be quite difficult. So the guidelines are very much hospital based, so difficult for us to necessarily put into practice, but monitoring input and output as best we can really. And we've now got some NHS England, NHS Improvement and CQC guidelines that have been updated. So you can see it's version 2 for legal guidance for mental health, LD and autism. And we'll be talking about those a little bit later as part of the case, but I suppose one of the updates that's kind of relevant to us potentially is that there have been provisions made as part of the Coronavirus Act and kind of changes to the Mental Health Act, is that although previously we were required to personally examine people for mental health fact assessments, there are some caveats only during the pandemic, so this isn't kind of a permanent change, that there are some situations where a video assessment would constitute a suitable manner to examine somebody. However, there's tons and tons of kind of caveats and things to kind of do before that would actually be considered, and it is a kind of case-by-case basis. There's individual assessments that need to take place, and the need to still make reasonable adjustments, and the video would only be considered if there's kind of a risk of harm via transmission or of COVID transmission to the person or staff, or if there's problems accessing PPE, if social distancing during the assessment wouldn't be possible, and if there's a significant risk of harm due to delay, and all of the safeguards are met, and there's a whole lot of safeguards. So I don't know if this is something that we'll be seeing much of, because actually there's still a need for the AMP, and often in most cases a first Section 12 approved doctor to be present in the room for the assessment, and then the second Section 12 doctor may be able to join by video, but there's a whole load of kind of safeguards and standards that are worth reading if that's something of interest to you. But I don't know whether anyone has had experience of doing this. I can't see a system where it would be particularly easy to set up, but that's kind of, so it's, but there is within the law some provision for that at the moment, and these are some of the kind of caveats and safeguards. Staff training, of course, contingency plans for video failing, reflection following the assessment, probably more things than even happen now, unfortunately, but anyway, so you can have a look at those. The guidance is very long.
Very long. All right, so on with the case then. We're going to talk about Mr. A today. So in this scenario, you are the SHO doing an evening on-call shift covering the local mental health wards and the medium secure forensic units, and you get a call about Mr. A, who is on the medium secure unit. So the nursing team are concerned that he's been drowsy and quiet and withdrawn, which is really out of character for him. He's been in his room all day and he doesn't want to come out for dinner, and when the nurse checked in on him for his hourly obs, he seemed a bit breathless. So you're on the phone to the nurse. What other information do you want at this point?
Yep, so starting with vitals, I think we're very well versed at this. I think you guys were doing ISPAR and all that sort of thing before the pandemic started anyway, but yep, absolutely vital signs. And asking about a cough as well. Anyone have any other ideas? Yep, so what's his fluid intake been like? Has he had a COVID swab? Does he have a history of asthma? Yeah, definitely it was very hot over the weekend, so fluid intake is important. Any anosmia, as we know that is now an official COVID symptom. Okay.
All right, let's move on then. So we get some obs while we're on the phone. We see that he's got SATs of 96%, heart rate 110, temperature up at 39.9, respiratory rate 19, and blood pressure of 130/85. So the nurse says that he's talking, but he's a bit drowsy. So what are you going to do?
Yep, so one thought about isolating. So I guess he's in his room, so we just want to keep him there basically. Make sure the staff are wearing PPE. Hopefully they're wearing kind of PPE anyway, but yeah, definitely. One thought about urine drug screen, definitely, yeah. Potentially if he's been having leave or even not actually, because we know that drugs can make their way onto the ward, of course. Yeah, so paracetamol for his fever. And I suppose one of the questions is kind of how quickly do we need to be seeing him, because that's always the kind of dilemma of being on multiple sites, is that kind of decision about, you know, how quickly can you get there, or is it the level where someone just needs to call an ambulance? I don't know what people's thoughts are about these observations.
Fortunately, in this case, we're having quite a quiet shift, so we can just head straight over there to see what's going on with Mr. A. So that's his ob summarised there, which does show a sort of low-medium level of risk. And you advise the nurses to keep him in his room and stay with him there, and to keep monitoring his obs every 15 minutes. All right, so you have a quick look at his notes before you go in to see him. You see that he's a 39-year-old British Asian guy from Barking. He's been diagnosed with treatment-resistant schizoaffective disorder, a mild LD, and he's currently on a 3741. He's been on the unit for 5 months, and when he was started on clozapine 3 months ago, his symptoms got much, much better. He had a COVID swab last week because another patient on the ward tested positive, and that swab was negative, and he has no leave at the moment. So you know that he's on a 3741. Index offence was ABH and possession of a bladed article in a public place. And he's got a few previous offences, including ABH, GBH and arson. Medical history, there's only a few things that are significant there. So he's got hypertension, recurrent DVTs and a vitamin D deficiency. And you have a quick look at his current medications. So he's on clozapine, he's on lithium, sodium valproate, rivaroxaban for the recurrent DVTs. He's on some cholecalciferol, amlodipine, ramipril, and lactulose. And he's also got lorazepam and promethazine covered on his T3. So, what are your initial concerns and your initial thoughts going in to see this guy?
So a really good thought about not just thinking of COVID, but thinking about NMS, myocarditis, PE. Yeah. So keeping it quite broad at this point. Definitely. So anything sort of medication toxicity. So he's on a number of things that can be quite risky. So lithium is one, definitely. Another vote for PE. And that we need to check his bloods, make sure we check his lithium level and his CK. Yeah.
And people suggesting that we get medical advice sooner rather than later, which I think is a fair point. All right, so these were the things that we thought about in terms of initial concerns. So we worried about sepsis, whether it's COVID, whether it's another infection, and whether it's related to neutropenia. He has been on clozapine for less than the 18 weeks, which is the high risk period for developing neutropenia. You can think about other clozapine related complications such as myocarditis. A few people have mentioned DVTs and PEs, lithium toxicity, NMS, and drug intoxication are all quite high on the list of differentials at the moment. All right, is there anything else you'd like to know before you go into the room to see him?
Yep, so just a point about kind of safety. So I guess a kind of recent risk assessment, what, you know, obviously he's in a medium secure unit, he's got this history, but also I suppose more importantly, what is he like at the moment? What's his mental state like? Definitely.
Sure. All right, so you managed to have a quick look at his most recent bloods on the system. So he had his clozapine bloods this week and had a green result 2 days ago with the normal CRP, normal troponin. His white cell count was 8, neutrophils 4.5, platelets also fine. Yeah, we've got multitasking with the comments as well.
A question about whether we even want to go and see him, I think, or whether we just want to send him to A&E. I guess that's the really difficult thing, isn't it, that we're always balancing when we're covering multiple sites and kind of trying to make a call about whether this person's going to end up needing to go to A&E anyway. I think, you know, he is going to need an urgent review. He is going to need bloods quite urgently. I guess the kind of perhaps caveat to that is that sometimes, you know, when you go and see someone, things either are a lot worse than you get handed over on the phone, or they can be a bit better. I got stuck in John Howard over the weekend seeing someone who initially had chest pain. It turned out they didn't have chest pain. So I think, you know, if there's a chance to kind of, if you can go and see someone first, assuming that they're not kind of completely obtunded, then you know, you would want to try and see them. But it's always a very difficult judgment call. So I certainly, you know, I don't think we have an absolute on that one.
Yeah, I think it's one of those situations where if you were on a separate site and couldn't get there very quickly, you'd be sending straight to A&E. But given that you're already on site,
yeah,
you'd probably see first and then get straight to call an ambulance if you think it's needed.
Yeah.
All right, so DSN collects you from reception and let's just confirms the history that you already know about and says that Mr. A has been really well since starting on his clozapine. He's not had any recent risk incidents. Prior to the COVID pandemic, he was being assessed for moved to a rehab ward, and there were some discussions about applying to the MOJ for more leave. He's usually quite talkative, friendly, and enjoys playing video games. But in the last couple of days, he's been off his food and just not really acting like his usual self. So you go to his room. What is your approach here? Might move through this reasonably quickly. Okay, so this is a really helpful bit of feedback from one of our service user peer reviewers, who said that when you go in to speak to him, once you've put on the PPE, make sure you explain why you have the PPE on in a way that will not trigger paranoia, to try and help with trust and to help not feeling paranoid. I think it's something we take for granted because we're putting it on and taking it off all day, but it is something that bears repeating to the patients. All right, so he tells you that he feels bad, but he can't specify. Quiet, to be any listeners. She's 14 out of Cate set above. Tackles or ways. So it's quite difficult to hear because of the tackle. He also managed to get an ECG off of him, which shows a rate of 115, but shows some premature ventricular complexes, which are new compared with an ECG from last month. His QTC is fine, and there's no ST or T wave changes. So, what are your next steps? Back to, all right, so that's what we're dealing with here.
Yeah, so good point. So put some oxygen on, because his sats have certainly dropped, haven't they, since we last saw him, and we're wanting to call an ambulance at this point, for those of you that hadn't already called an ambulance on your way over. So ambulance, oxygen. I don't know if there's anything else to do at this point except to continue to monitor him.
Yeah, fair enough. So you arrange an ambulance to take him to A&E straight away. You explain to him that you want the medical doctors to check his physical health, and he's okay with that. You need to have a discussion with the ward team, and they know him quite well. They think that the absconding risk is quite low. Call A&E, hand over, you call the first on, you ask to notify his family. So there's no need for a Section 17 leave here because he requires urgent medical care, and is regular in the morning. We'll need to contact the MOJ to inform them about the transfer. All right, so let's talk about COVID CLOZAPINE. So it's really important to remember to rule out other causes of infection and to think about neutropenia. And remember that if someone's presenting with flu-like symptoms or chest pain or breathlessness, you have to have quite a high level of suspicion for myocarditis, so you'd withhold clozapine and taste myocarditis while I was thinking about other differentials. Lithium and COVID-19. So diarrhea, vomiting and fever can all contribute to dehydration, which could lead to an increase in lithium levels and potentially toxicity. And bear in mind that lithium toxicity can look a bit like some of the symptoms of COVID-19. So weakness, reduced conscious level, and diarrhea could be a presenting feature of either lithium toxicity or COVID. The recommendations at the moment, if someone's got mild symptoms of COVID, you keep going with the lithium and the routine blood test monitoring. And someone that's got moderate symptoms, you'd be a bit more inclined to do an urgent lithium level and use an EASE and think about suspending the lithium based on the clinical symptoms. And if someone's got severe symptoms of COVID, you want to stop the lithium and urgently do a level and some use an EASE.
And I suppose it's also a good time to remind people who are, probably already aware when they're taking lithium, but not using NSAIDs or starting new NSAIDs, just in case they were thinking. Hopefully, no one is taking NSAIDs as well, but
you'd hope not.
Yeah.
Although the advice is someone's already on an NSAID to maintain it, so don't make any sudden changes. All right, so he goes to A&E, and as per this flowchart that we've shown you before, he would get admitted. All right, so he's arriving in A&E around about handover time, and the night SHO asks you what you think should happen about his nighttime medication. He's not yet been seen in A&E. What do we think should happen?
I think we have a question coming, do we? Yeah.
Oh, right, okay. So you discuss with the SPR, you agree to wait for bloods, but you think you might have to hold the nighttime clozapine and lithium if the clinical presentations are unclear. And you could advise giving some PRN benzos for agitation, with the caveat that if someone is suspected of COVID, that you'd want to use a short-acting benzo in case it needs to be reversed. Okay. So the next day, you're covering liaison in A&E. You're going to speak to the medical team about him, and you have a quick look at his notes and his bloods before you go and speak to the medics. So you see that he's been admitted to the hot ward and he's on a 2-to-1. He's still drowsy with no agitation, and he's been accepting treatment. The MSU staff have been facilitating phone calls to his family. He's still got a fever. His SAT's dropped down to 90 overnight, and he required some oxygen therapy. And his clozapine and lithium were withheld overnight. The medics have sent a clozapine level, which is not back yet. It's taking about 3 or 4 days still at the moment. Lithium level is 0.7, taken at 10 o'clock at night. And his usines are, as you can see here, the CK of 350, troponin negative, D-dimer fine, and CRP 112. So he had a chest x-ray which showed some peripheral consolidation. They've done a COVID swab, which the results are not back for yet. And the current working diagnosis is COVID with a differential of hospital-acquired pneumonia. Started him on some IV antibiotics, PIP and TAZ, and some IV fluids as well. So they did some continuous cardiac monitoring in light of the unusual ECG that he had. And what that's showing is that he's having occasional premature ventricular complexes. He's still tachycardic, going up to 140. But his QTC has been fine and there's no dynamic changes. So there's a plan in place for a cardiology review. So should he have his clozapine this morning, and should he have his lithium tonight? What do you think?
So there's one yes, one maybe holding clozapine, continuing lithium. Clozapine could be causing cardiac issues, maybe wait for cardiac. No for clozapine. So there's a variety of views, I think it's safe to say.
A whole range.
I think we've had all of the
We've had every possible combination of options. All right, so you have a talk with the SPR about it and have a think about what's going on here. So they've got this current working diagnosis of COVID plus or minus bacterial pneumonia, got a negative trop, and no signs of myocarditis on his ECG. It's not neutropenic, no signs of PE. His renal function is stable, and a random lithium level, which was done at 10 in the evening, was not raised. So you agree to continue the clozapine and lithium and hand over to the liaison team for ongoing review in the coming days. And there's a plan to do a proper lithium level the following day. All right, so the following week, you follow up on the case by looking at his notes. You see that he's tested positive for COVID. He only required oxygen for 24 hours and then he stabilized. And when cardiology came to review, they felt that the PVCs were most likely benign. The tachycardia had resolved and had gone back to a baseline of 90. So after a few days on the medical wards, he was transferred back to medium secure after 3 days.
There's a question about whether this is moderate or severe COVID, so whether the lithium should be stopped. I mean, I guess we've had the luxury of having his renal function checked and we've checked his levels. So I suppose that's kind of, he's going to be monitored, he's going to have daily bloods, and he's, yeah, I mean, I suppose the differentiation is quite difficult. I don't know what you think.
There aren't really clear criteria is the problem, and if you look at different sources, they'll give you slightly different criteria for what constitutes moderate or severe. But as you said, if we know his renal function, then that does give us a bit more information to make the decision off of.
Yeah. And I suppose there's other factors to be deciding about in terms of risk of kind of stopping something in someone who, well, obviously everyone is on medication that they need, but, you know, potentially a high risk person. So if you're in the facility where you're able to actually monitor bloods and renal function, then that might make it safer to continue something. Whereas if someone's in the community, then you can't monitor them as well. So,
sure,
you know.
Absolutely. All right, so the following week, you're back on call again on a Tuesday evening, covering the wards and the medium secure unit. The SHO has handed over bloods for Mr. A for you to chase. So they've got his clozapine level back from 5 days ago, and that came back as 1.95. And they've repeated the bloods this morning, including a lithium trough level. All right, so you do chase the bloods, and this is what comes back. Highlighted the abnormal ones in bold. So we already know about the high lithium level, but we can see his white cell count is down, his neutrophils are down as well, and his lymphocytes are down. And we can see that his CRP is very mildly elevated too.
But then it's obviously come down since his hospital admission, so that at least is trending in the right direction.
Yeah, that's
everything
reassuring.
else.
Everything else is a bit of a concern. All right. Okay, so what do you think should happen now in light of these blood results?
Always good bloods to get on an on-call.
Yeah, lovely.
So holding clozapine and stopping lithopine. Wow, I just made a new medication. Yeah, so basically stopping everything.
Yeah.
Okay, we agree more on that one.
Yeah,
I think
there's a bit more of a consensus here.
Yeah.
Absolutely. Okay. So you go and cast an eye over him first. You see he's calm, he's in his room, good food and fluid intake, no focal symptoms. He's still got a bit of a dry cough and a fine tremor. His obs are, as you can see here, and he's not got a temperature and hasn't had one since returning to the medium secure unit. So we've already talked about what we think should happen with his medication. All right. Clozapine and COVID. So we know that COVID can cause a depressed lymphocyte count, but it doesn't on its own reduce neutrophils. So when we're monitoring white cell count in clozapine patients, what we're doing is looking for neutropenia and granulocytosis. So actually having a low lymphocyte count is not that concerning in the grand scheme of things. So the most recent guidance that's come out from SLAM is saying that if someone's got COVID-19, then you should interpret their white cell count in the context of the neutrophil count. So if the lymphocyte count is giving you a sort of a low overall white cell count, but the neutrophils are normal, then the recommendation is that you can safely continue clozapine. And you can have a look at these links here if you want to read the guidance in a bit more detail.
But of course, that's not the case for our man.
So no, our guy does have low neutrophils, so that does change things slightly. So remember that if there is a neutropenia, then the usual amber or red guidance applies, as you can see here.
And it potentially depends on exactly which type of clozapine you're using. There's probably some slight variation in terms of that green, amber, red kind of thing, which is why you would definitely discuss with your on-call pharmacist as to which exactly is where I look at the kind of ELFT policies.
I mean, each brand has got separate guidance. I didn't bother summarising them all here because, yeah, it's 3 different sets of guidance. Okay, so having discussed with the SPR and the on-call pharmacist, they both advise you to stop the clozapine as per the red guidance. They also advise stopping the lithium and monitoring daily electrolytes and encouraging fluid intake. You ask his team to review his medication again tomorrow morning, and you discuss with the nursing staff about doing 15-minute OBS and QDS vital signs. And you continue the recommendation to self-isolate in his room, bearing in mind it's been less than 7 days since he was diagnosed with COVID. But once you finish documenting all your notes, you wonder about why Mr. A's clozapine level was so high. Do you guys have any thoughts on that?
Yep, so possible medication interactions.
Medication error. Lots of people pointing out a change in smoking history, which is quite plausible if he's just gone over to the medical unit, or if there's been changes to leave or things like that. Or if he stopped smoking because of his breathlessness.
Definitely. So probably for our patients on the non-secure wards, it's much more kind of a relevant issue, because people start and stop smoking and have leave and don't have leave and all that sort of thing. For this gentleman, he wasn't having leave anyway, but yeah, definitely an important one to think about.
Any other thoughts on why the level might be so high? So I suppose it's important as well to think about the time of day the sample was taken. Was it actually taken at the right time? Question about dehydration, not so much with clozapine, because it's mostly the hepatic metabolism that affects levels. So we've got a few suggestions here, some specific to COVID-19. So we know that fever and increased inflammatory response can inhibit cytochrome 1A2 metabolism. We also know that erythromycin and Cipro can both, which are both used to treat secondary bacterial infections, both of those can increase clozapine levels. And as a lot of people mentioned, stopping smoking due to physical illness or reduced Section 17 leave or other circumstances, all of those things could increase someone's clozapine levels. All right, so later in the week, you start weekend nights on Friday and you're called by the medium secure unit to say that they've had to seclude Mr. A. We're just going to throw back to this NHS England guidance that we mentioned in the update slides.
So I guess we do now have some guidance, which has just come out really in the last week or so, because when we presented kind of a case previously, we were talking about kind of managing seclusion, segregation, all these kind of different options for people who can't maintain social distancing if they've got COVID, and we've got a slide later with the Alex Rutkin paper that we talked about before. But there is now some kind of NHS England guidance, but essentially the key things are that we shouldn't really be using Mental Health Act powers to enforce treatment or isolation for someone who's not isolating, unless it's to do with their mental health issue. So it shouldn't be used to just keep people for testing or anything like that, because obviously we have the Coronavirus Act, but of course we're not quite sure how to use that yet anyway. But it does kind of make provision now, which was kind of really a grey area, that the Mental Health Act may offer some authority for enforcing social distancing on wards of symptomatic patients, but still bearing in mind the principles in the Mental Health Act Code of Practice, which we can see below there.
So you're on the phone to the nurses who've just secluded Mr. A, and they tell you that he's becoming increasingly difficult to manage, and this is what's led to the decision to seclude. So he's become fixated on 2 of the nurses on the ward and on 1 other patient, and has been making threats to kill them. He's also been making allegations that this other patient had come into his room the night before, although nursing staff were pretty confident that this didn't happen because the other patient was on a 1-to-1. He's been trying to spit on staff, and he's been insisting on using communal areas of the ward. So you have a quick look at his notes, and you find that since his clozapine and lithium were stopped, there's been increasing paranoia, increasing persecutory delusions about staff. He's been responding to auditory hallucinations. There's no overt violence, but he's been acting in an intimidating manner with staff, so glaring, making intense eye contact, stamping his feet and making sudden movements in an intimidating way. His team decided to start him on Clopixol on Wednesday, so that was a couple of days ago now. And he's meant to be having QDS observation, but is often refusing. And so his last set of obs were yesterday, which were all within normal limits. So having a quick look over his psychiatric history, you see that he first presented to services with the first episode of psychosis back in 2004. And since then, he's had a few relapses, which are usually characterized by derogatory auditory hallucinations, paranoia, which is often fixated on specific individuals, grandiosity, and thoughts about harming people. You can see that he's had a poor response to olanzapine and aripiprazole in the past, and he had pretty bad hyperprolactinemia when he took risperidone, but he has been on Clopixol in the past with some benefit. And prior to this admission, he was under the care of the Community Forensic Outreach Service. So what's your approach to this seclusion review? What are you going to do?
I think we haven't had a seclusion review since week 2, maybe even. So
yeah,
it's good to come back around.
Circle back on that one. That was a long time ago.
Yeah. So some thoughts about medication, maybe lorazepam if his respiratory function is okay. A question about what medication is he on now. So that's definitely a good thing to check. So we'll talk through that shortly. Definitely, so thinking about, you know, the safety of the team, and also, you know, what kind of PPE would you be wearing going into this? Someone suggested very helpfully to wear a visor because we've heard that he might be spitting. So need to think about question of benzos and the kind of risk-benefit safety of his, because he's recently been discharged from hospital having had COVID, but obviously he's now presenting a different sort of risk, and maybe some thoughts about haloperidol.
All right, so we've shown this slide before, but it's just a summary of what PPE you can think about using in a seclusion or restraint situation. Just highlighting that aprons might be a hindrance or a slip hazard, so that's something to discuss with the team before going into the room. But otherwise, everything else is found to be effective. So everyone gets a PPE on. We plan to do physical health, full set of obs, look at fluid intake and orientation and signs of confusion, and also to assess his mental state and his meds, his insight into his behaviour. So you go into the seclusion room, he's sitting in the corner, he looks fearful and wary, and he allows you to check his stats, so that's 97%, and his pulse is 100, but he pulls his arm away before the blood pressure can be checked, and he refuses his temperature. He does take medication with a lot of prompting, and recognises one of the members of staff from his own ward. He does accept some food and fluids, and he seems to be reasonably well hydrated, but he's asking about going back to the ward, but saying that he's worried that other patients want to give him corona, and he says that he'll hit the other patients if they come near him. He's also telling you that he's really tired and wants to get some sleep. This was another bit of feedback from our service users, peer reviewers, pointing out that it'd be really helpful to get down to his level and try and reassure him about why people are wearing PPE. So he's telling you in this scenario that he's worried about people giving him coronavirus. And yeah, I suppose it's just to reiterate that it can be quite scary, it can be upsetting. And if he's been in seclusion before with staff not using PPE, this might be a bit of an unusual situation for him.
Yeah, definitely.
All right, so he's reviewed by the on-call consultant the following morning, who decide on the following plan. So they think that seclusion is still necessary because of the ongoing risk of violence, but they'll obviously keep reviewing that on a regular basis. Clipixol is increased with a plan to check his ECG, continue the valproate at his 1.2 grams, and obviously his clozapine and his lithium have been stopped. The decision is to use lorazepam as PRN, obviously with some caution. And section 62 is completed. We managed to do a food and fluid chart and do some physical health monitoring.
I suppose we can just answer the question. His respiratory rate appeared to be normal, and he was kind of obviously quite shy and sitting in the corner, but he didn't seem to be in any respiratory distress from the seclusion review.
All right, so during subsequent seclusion reviews, it's discussed whether, well, there's a range of options. They could either keep him in seclusion until his mental state improves sufficiently for him to be able to follow guidance about remaining in his room. You could nurse him on one-to-one in his room, or they could try segregating him in his room. What are your thoughts on the best options for Mr. A at the moment?
So some votes for A because of the risk to others, because I suppose we've essentially got someone who's got a kind of rebound psychosis, having stopped clozapine. And I guess previously our concerns were about his physical state, and we do still need to keep that in mind, but maybe seclusion actually allows us to monitor both, because actually it means that he has someone who's kind of observing him, looking at his kind of respiratory rate. Obviously it's still quite restrictive though, so difficult. And I suppose it's kind of what is the reason for him being in seclusion as well? Is it to protect other patients from his potential COVID, or is it because he's actually kind of risky in other ways, which it sounds like he was actually, he was kind of quite intrusive and kind of paranoid and threatening. So, but yeah, I think it's kind of a question that is still very much up for discussion.
Very rightly pointing out that seclusion should always be a last resort, and so I suppose the question on everyone's mind during these reviews is, you know, is there another way that these risks could be managed?
And I guess, as with all kind of you know, MDT reviews and discussions, it's kind of thinking about what the nurses feel they're able to manage. They probably know him very well. He has been on the ward for 5 months now, so they may have, you know, a lot of very helpful thoughts about what would be the best way. I guess the thing about having a one-to-one is the risk to the one-to-one, potentially, depending on what the risks are. And the segregation one, if you're kind of locking someone in a room but not necessarily observing them as closely as you would in seclusion, that may not be very helpful for someone who's kind of potentially got other respiratory kind of problems. So difficult to know.
Sure. So I mean, there's a lot of things to take into consideration, most of which we've already discussed. So we need to think about his capacity and what efforts we've made to support his capacity. We need to think about his reasons for not complying, which at the moment does seem to be partly related to his psychotic symptoms. And to think about his level of disturbance, the degree of severity of his physical health problems, risks to self and others. And then also thinking about other interventions that could support. So, you know, if you could give him access to his phone or a radio or nicotine replacement or other activities, would that support him to be in his room safely? And I think it's a bit further up in the comments, but Ellie did quite rightly point out that he might be quite reassured and settle more quickly in a familiar environment like his own bedroom.
So I guess just another kind of link to this paper, which we did discuss previously, but it does kind of outline a number of kind of different circumstances that might be relevant. I guess it's worth knowing that this was published before the NHS England guidance came out. Not that that gives us kind of all of the answers, but I guess we do have at least some kind of a bit more information about what the CQC and the NHS England think how we should be managing these problems. But there's a huge number of ethical, kind of legal and practical kind of challenges that continue to exist. And I guess the relevant cases that are described in this paper, which are also fictional, describe one case of someone who's kind of agitated and psychotic and not adhering to social distancing for those reasons. And then there's another case described as someone in a forensic unit who actually isn't mentally unwell, has COVID and is kind of wanting to infect other people just because they're not a very nice person. So there's kind of a different approach for both of those situations. So I guess it is like anything, kind of understanding the reason for the behaviour and then kind of responding appropriately. I suppose the other thing to say is that NHS England guidance has a lot of kind of important information and safeguards to think about with regards to like what you've mentioned about making sure that people still have some activities, some distraction, some kind of things to keep their mind distracted from the situation, and also just to kind of be aware of that I'm really pleased to see that there is actually specific mention of people who've got a history of trauma and the impact of kind of segregation, seclusion, restraint on people. And the fact that that in itself is a traumatic experience. So at least there's some mention of that.
All right, so Mr. A, over the following days, he remains paranoid, but he accepts food and fluids. He refused OBS or investigations about 50% at the time. And the team did try to work around this, so using clear communication, using the staff members that they knew he had a good rapport with, and trying to take opportunities when he arose. So when he started getting a little bit elated and more friendly, they sort of jumped in and started trying to get more OBS and ECGs and things like that when he was a bit more amenable. So after 48 hours, his mental state had improved enough that the team felt that they could end seclusion, and he agreed to stay in his room. Just a final point to think about, before he goes back to the ward, it's really important to mention that he's worried about patients giving him corona, so kind of helpful to explain why he and his peers don't have to wear PPE at this point.
And I suppose there is some information out there that's kind of written for people with LD about COVID and that sort of thing. And I guess, as we pointed out before, OTs can be quite helpful in communicating kind of the description of the social distancing and that sort of thing for people who may struggle with that normally. I guess he's now out of the 7-day period, but that doesn't mean that there aren't other people on the ward that might have COVID. So yeah. We still don't really know if you can get it again, but anyway. Yeah.
Cool. So I think that's it for our case. So remember to think about clozapine and lithium related complications. at any time, but particularly patients with fever and drowsiness. And think about the management of patients who are refusing to isolate. So it's going to be a case-specific decision, and it's going to be an MDT decision.
And I suppose the other thing to say is that the guidance overwhelmingly says we should try and cohort people, because that's actually the least restrictive thing. But there's also a caveat in there that that may not be possible because of ward space and particular situations, and that if you're going to cohort, you need to also think about the kind of divisions between gender wards and that sort of thing. But yeah, cohorting would be fantastic, but not always possible.
Sure. All right, so as always, there's some resources to have a look at the end. And just once again, huge thanks to all our peer reviewers and to the MedEd team for all their support. All right, back to Juliette.
Thank you. Thanks, Lynsey. Thanks, Cate, again, for a brilliant case. Thank you, everybody who's taken part. Thanks again to our expert reviewers, Elinor James, Mack McLean, Richard Latham, Catherine Marshall, and Lenna Adley. And thanks to the MedEd team. Thanks to everyone from outside ELFT who's joined us. We're just going to hand over to Paul, I think, for some brief updates. I'd like to say he's in a rose garden, but I don't think he is. Hi, Paul. We can't hear you. I don't know if anyone else can. Presumably not. You can unmute. We still haven't been able to hear you, Paul, so we're just suggesting that if anyone has any questions, that they could type it in the chat box, or you could perhaps type some of your updates. It's a bit old school. Sorry. Well, people are suggesting if you try and take the microphone off or take it out and just using the computer audio, if possible.
Check. Is it working now?
Yeah, brilliant. Well done.
Right, so I've not got much time left and I don't want to take up too much of your time, but a couple of things. Forensic, it was really good to hear Forensic today. Forensic's been one of our hotspots for COVID positive cases, and as you know, I myself am a consultant forensic psychiatrist. During the COVID outbreak, we've had 29 positive cases on the forensic service, all in medium secure, none in the low secure department. 2 patients have actually tested positive twice, with a five-week gap in between, and also been symptomatic on both occasions as well, which gives us a slight cause for concern. Of the 29 positives, 5 were actually transferred to the acute services because they were in respiratory distress, although none required intensive care or ventilation, and all were returned safely. So well done to the forensic services for managing those cases so expertly through that difficult time. As I mentioned last week, we're now on phase 2 of the COVID pandemic management. We've set up the 5 steering groups or work streams, shaping future services, which will look at how we develop future services for the new normal, future working, how we manage to socially distance at work and what we need to do that, and how we develop new patterns of working, leadership, and how we tool up our leaders to be equipped to lead this new workforce that we're going forward with. Inequalities, which I think we know all about, the inequalities that COVID has shown us, such as in BAME staff and BAME populations, also in our learning disability population, and also in our elderly population. Lastly, co-production, which I've just come off the first meeting of, which I actually sit on, which I think is a really important work stream. It goes through all the others, but really it's to define what is co-production and how can we ensure co-production takes place in all that we do within ELFT. How can we look at the communities and what communities have done to be resilient, and how can we co-produce with those communities to maintain that resilience? Then lastly, about how we can co-produce with our other stakeholders to develop new systems for working right across the system in the future. So a lot more will report back as this is going on, but in the meantime, please keep safe, and thank you once again today for an excellent presentation. Thank you, and apologies about the sound quality.
Thanks, Paul. Does anybody have any questions for Paul at this stage? Any burning questions about those points? Can I ask Paul? I know that the board have been looking at all of the deaths that have occurred within the trust. Is there anything that you want to tell us about how those are being looked at, or?
Okay. So at the moment, there's a couple of pieces of work going on. So I've asked for all the reported deaths from COVID to be reviewed, just to check if there's any teams going through with them already. Just on a kind of eyeballing, it does seem an awful lot are taking place in care homes, and be they in contact with district nursing services, community services, or community mental health services, particularly in the elderly and the learning disability. So we'll have a broad look at those. In total, we've got 111 service users have died during the pandemic. Of those, 20 died in the community, the others 20 died as inpatients, the others in the community. Of the 20 who died as inpatients, 5 were transferred to acute hospital and subsequently died, which 15 died in their care. Many of them on end-of-life pathways already due to frailty. But the 15 cases I've asked to particularly have a look at to check, did they receive the appropriate care whilst an inpatient? Why didn't we transfer them to acute hospital? And was that the most appropriate thing to do? So we'll review those 15 in a wee bit more detail than we will the whole group of 120. But I think there is some work we've got to do across that. Yeah, and then there's also a cluster. Cluster's the wrong way to say it. There was 6 suicides occurred in Hackney in the 4 weeks of April. We're also looking at them in quite a bit of depth as well. And after this call, I'm going to speak to the public health people in Hackney. They're talking about whether it's a cluster or not. We've looked at the cases, and there's not a common theme going through them. They're from different age groups, different ethnicities, different backgrounds. There is bits of COVID in 3 of the 6, but nothing that's kind of a communal. Somebody had phoned the crisis line 3 nights consecutively to talk about anxieties they had about COVID. But I can't see anything that would say it's a cluster as such. I think the public health people get quite excited when they see a number of suicides happening, but being random, suicides do tend to occur in kind of a cluster form as well. Sorry, did that answer your question?
Yeah, thank you. There's a couple of just quick questions about risk assessments for BAME workers and antibody testing.
So, antibody testing, I've not got much detail at all on at the moment. I'm quite surprised. The government has announced antibody testing, but we're getting no idea from the centre on how we're going to have access to antibody testing and rolling it out. Obviously, it's something we want to get as soon as we possibly can, and as soon as we get details on that, we will be passing it out to you. I mentioned about the vulnerability risk assessment that we were doing, and that, I think, went out yesterday on the intranet and through the COVID bulletin, so people should have it. The purpose of it is to give us a structured way of looking at risk assessing people in clinical situations. So it's looking at not only BAME, but looking also at gender, at age, and underlying conditions as well. It's aimed at not being too prescriptive, because we want it to form a really structured discussion between a member of staff and their manager about what their risks are, and also what they're doing to mitigate against those risks. You know, do they have access to the PPE they need? Do they actually need to be moved, maybe perhaps to a less, if they're so risky, should they be working in a COVID positive ward, or should be in contact with COVID positive people? So we have to look at all these factors and look at how we can manage our workforce. The important thing is this discussion is to aid staff in feeling safe and feeling heard. So it's important those discussions take place over the next couple of weeks.
Thank you. So it'd be interesting to hear if anybody's used those with any doctors. Any doctors have had those discussions with supervisors.
I would be encouraging juniors to be saying to their consultants, you know, can we have this discussion? I've heard about a risk assessment tool. Could we discuss that and go through that with me? And to consultants, please be discussing this with your trainees. And with consultants, I think it's going to be the clinical directors who are going to have to carry out the risk assessments with consultants. But it should be for all staff. It's important to say that as well.
Thank you. So we're not here next week because it's the Bart's afternoon. So if there are no other questions, we're going to end it there for today. Thanks, guys, so much. Thank you, Paul, for joining us.
Thanks
everyone for taking part.
Care.
We'll see you soon. Bye-bye.